All right. Well, I'm excited to introduce our next speaker. This is Dr. Jin Ji. He's a gastroenterologist and transplant hepatologist here who specializes in caring for patients with advanced liver disease, including those awaiting transplant. His research applies clinical informatics, data science, and artificial intelligence to improve outcomes for patients with complex medical issues, particularly those hospitalized with liver disease. He earned his engineering degree from Princeton and his MD and MBA from the University of Pennsylvania. He's done his internal medicine residency, GI fellowship, and transplant hepatology fellowship here at UCSF, along with advanced clinical research training in data science. He's a faculty member in the Division of Gastroenterology and Hepatology and an affiliate faculty at both the UCSF Bakar Computational Health Sciences Institute and the UCSF UC Berkeley Joint Program in Computational Precision Health. As trainees, we're lucky to work with Jen on LTU as well as in the ambulatory setting where he's taught us many pearls and mentored and supported a lot of us fellows. Take it away, Jen.
Thank you, Stephanie, for the wonderful introduction. And I want to give a plug for the Minnesota Tube training session. That's next. I think that's next Wednesday. Is that correct, Steph?
I believe.
Yeah, that's correct.
Yeah. So we're super excited for that, and some of you guys have had experiences placing Minnesota Tubes with me, so it'll be a rehash of that experience. I don't know if Grace is online. But I'm here to talk to you guys about cirrhosis and consult calls, and just be aware that cirrhosis is a very, very big topic. Like a lot of hepatologists devote their entire lives to it. So this is only going to be the very basics and sort of like what things that you may get called for when you're rotating on consults at all three of the sites. Here are my disclosures. So I do run a artificial intelligence and clinical informatics lab, and a lot of that is supported by grant as well as industry funding. And so they asked me to include this slide just to make sure that there are no conflicts of interest, which there are none for this presentation. And to start things off, like this is just an acknowledgement that cirrhosis itself is a very, very complicated clinical condition to manage within, all of GI and also liver diseases. There's a lot of different etiologies. People progress at very different velocities and paces throughout their clinical journey. And the complications of cirrhosis are quite difficult to manage longitudinally, also in the acute setting. And I think one of the problems that underpins cirrhosis management is that liver transplantation ultimately is the destination therapy that fixes the problem, but it's a scarce resource, and not every single patient will be eligible for transplant. And because of the nature of cirrhosis complications, I'm sure you guys seen this as internal medicine residents, that hospitalizations are very common for this patient population. They tend to get readmitted pretty quickly. They have an extremely high mortality rate in the hospital. And the evidence for cirrhosis management is actually evolving very rapidly because of the variety of the different decompensations. So, back in the day when I was a first year fellow, we actually would meet on the second floor conference room, and I think like all the first year fellows had to stand up as the attendees are calling questions. You guys don't have to stand up now, but I'm still going to ask questions. So I will pick unless somebody volunteers, I'm going to pick a first year fellow to answer this question. But I guess to start with something super basic, what are the components of the MELD score in 2025? Anyone want to take a stab at this?
Let's say C.
Do you want to rethink that? Royce, I just saw you a couple of days ago.
Hi, Jen. Is it E?
E. Okay. Are you sure not F? Because that's what I would do. I just go on MD-Calc and just like plug it in. So it is E, and the key part is in 2025. Everyone knows about the MELD score, the original MELD score, which is, answer A. That includes the bilirubin, creatinine, INR. And before 2023, before the middle of 2023, the MELD score was C. So Gloria, you are partially correct. It was the MELD sodium. But since then we are now in the third version of the MELD score. And I think this is something that you just have to remember now, because it is quite important. And you may wonder, why do we have three versions of the MELD score? And so this is the history of the MELD score and its use for transplant allocation. So back before 2001, transplants were being allocated based on the Child-Pugh classification, which included subjective measures such as encephalopathy and also ascites, because who gets to judge what is severe encephalopathy or who gets to judge what is severe ascites? And people have found that the Child-Pugh score and classification was actually prone to a lot of gaming for transplant allocation. And so there was a pivotal paper that came out in 2000, which looked at MELD as a predictor for a clinical predictor for TIPS. And this was validated on patients with cirrhosis, and then the MELD score became a part of what we do for use for allocation since 2002. In 2003, and again 2008, Ray Kim did a study which was looking at the addition of sodium into the MELD score, and found that this was much more correlated with yielded a much better prediction. And so MELD sodium was adopted in 2016, but this changed in 2023, and this was because I think people started to understand that the MELD score and MELD sodium was associated with persistent sex-based disparities within liver transplantation. This is a very nice graph that Jen Lai actually created, which looked at sort of the discrepancy between men and women getting liver transplants in the United States, and how the MELD sodium and the MELD score did not really correct this issue. And so this led to the introduction of MELD 3.0 by the group over at Stanford. And this was adopted by UNOS in July of 2023. And so I think the notable things is that now the MELD 3.0 now includes a 1.33 points if somebody's sex is female, includes serum albumin, and there are certain bounds around the values of the biomarkers, just to make sure that they are fit into the model itself. As you can see, this is a very long equation. Although I love equations, this is not something that you can calculate just off the bat. And so I typically will go to MDCalc or the UNOS website to calculate this. And also within our Epic EHR here at UCSF, and I think this is also true over at ZSFG, you can actually type .MELD, which calculates the MELD 3.0 for you. And so very accurate formula. And so I highly encourage you guys to do that. So we're going to talk about a case, because that's going to be illustrate some of the decompensation of cirrhosis. So we got a 54-year-old man with alcohol-associated cirrhosis. He comes to the emergency room. He has worsening ascites. He stopped drinking about 3 months ago. He denies any encephalopathy. And then he vomits 3 cups of bright red blood before coming to the emergency room. And so I think this is a pretty typical consult that you guys are going to get as first-year fellows. You do the things you do in residency. You start the pantoprazole, you start the octreotide, you start the ceftriaxone, and then I guess the medicine team calls you and asks you, what are your thresholds for transfusing this patient with portal hypertension? So Karina and Vincent over at Team ZSFG, it's your turn.
Okay, sounds attractive.
Yeah, I would think A.
Yeah.
All right. Is that your final answer?
It's our final answer.
Okay. It's actually C now. So you just transfused for hemoglobin. There's actually no targets for platelets and INR. And this is a new update, and this is based on the evolving literature. Now, I would have to say that a lot of this will also depend on who the attending is on, and sort of like what their preferences are and what their comfort levels are. But officially, if you go to the clinical practice guidelines for the ASLD, C is now the official answer. And this is the part of the you're assuming somebody who has hematemesis and has portal hypertension. It's a variceal bleed until proven otherwise. And so this is the guidelines from 2024 from the ASLD. In the acute variceal hemorrhage, the initial management is that you are initiating a vasoactivation, you give antibiotics. You should perform endoscopy within 12 hours of the presentation, which is logistically very, very hard. But I think the notable things is that you should avoid the use of routine FFP platelets or cryoprecipitate, and you should transfuse for hemoglobin above 7. And this is because people have done multiple randomized trials and meta-analyses, and they looked at restrictive versus liberal transfusion. And what we found was that restrictive transfusion thresholds actually has lower rebleeding and no difference in ischemic events. And the thought here is that if you end up giving additional products that are not red blood cells in this situation, you may actually precipitate an increase in the portal pressures and inadvertently worsen the bleeding. And so this is one of those ironic situations where FFP and platelets may not be helpful in the acute management. There are actually no targets for INR or platelet count, and this is recognizing that a lot of these patients have large spleens and thrombocytopenia that are refractory to transfusing platelets. And what typically happens is that somebody comes in with a platelet of 40, and you end up giving them a unit of platelets, and their platelets bump from 40 to 42, and that's a very, very common scenario. And the INR in this situation is not actually reflective of their coagulopathy. It's actually more reflective of their synthetic dysfunction. And so correcting the INR doesn't really have a specific, a goal in this situation. And so these are the official practice guidelines from the ASLD. And they basically state that under guidance statements 28 and 29, targeting a hemoglobin of 7 unless there are conditions that require higher hemoglobin, notably in CAD. And also 29 is that fresh frozen plasma and platelets should not be administered for an INR or platelet target because there's no evidence of such transfusions in the variceal hemorrhage. So this is a really nice study that was published in JHEP reports back in 2021, but they looked at basically about 500 outpatients with cirrhosis who were undergoing esophageal band ligation. And what they saw was that the post-banding bleeding events were uncommon and unrelated to platelets or INR or transfusion of blood products. And the thing that was associated with bleeding was actually higher child puke scores and MELD scores. And so the idea here is that it's not so much that the specific INR or platelet levels that actually matter, but more of what is their overall cirrhosis status and what is their overall clinical status that drove the risk for bleeding. This is a very common question that comes up from cardiology. They always come and ask, hey, I'm going to be doing a TEE in a patient with cirrhosis. Can you sculpt the patient to make sure they don't have varices? And there's been multiple studies on this. Mike Lee wrote a paper that was published in, I think, Hepatology Communications a couple of years ago. This is another study that came out in 2022, and now it's in our guidance statements. So if the cardiologists come and ask you to please do a TE, please tell them no respectfully. And if they come back again, tell them to please don't ask this question again, and give them this literature. So, and this is in the guidance statement. It says, guidance statement number 57 says, routine upper endoscopy prior to TE in cirrhosis is not recommended. So, all right, case 2. So you sculpt the patient, you do banding, you put on 7 bands, which I think that's only possible at the general with Super 7s and not the 6 shooters we have at UCSF. And then because you gave him midazolam and fentanyl for his EGD, he's now A0 times 0 clonus, unrousable to verbal stimuli, and withdrawals to painful stimuli. So, all right, this slide actually gave you the answer already, but what are your next steps for management for severe HE? We're calling this GCS7. And basically the answer is to intubate, place a feeding tube for administration of lactulose, rifaximin, and plus or minus PEG, and then adjust the dose according to mental status and stool output. You should not check the pneumonia. You can think about giving flumazenil. That's a good idea, but a lot of times this can precipitate a seizure, so just be aware. So this is a quick diagram of a step-by-step for management of hepatic encephalopathy. This was published in 2002 and written by Jas Bajaj, who's a world expert in the management, in the pathophysiology management HE. And a lot of this, I think, the things to emphasize is that when you do have an episode of a patient presenting with hepatic encephalopathy, you always just want to try to figure out what really caused the encephalopathy. is this an occult infection that we're not capturing? And so you really need to obtain the appropriate labs, obtain a TAP if possible to rule out SPP, look at whether there are any sort of like toxins that might be contributing to this, and as well as try to suss out from the history if there is any medication non-adherence that might be driving it. And then the therapy is basically lactose rifaximin and try to get them to poop. And I think one part of the encephalopathy management sort of like life cycle or the steps is that discharge planning is super important in this patient population because you want to make sure they don't come back into the hospital. You got to make sure that they have all of their appropriate medications, know how to use them, and be able to get them at home so that they're able to manage this at home. And I think like being able to get the medications at home is a big challenge because a lot of times there may be some approval issues with getting rifaximin. So this is a really nice study from 2014, which looked at bowel prep for hepatic encephalopathy. And what they did was that they had analyzed lactulose versus go lightly for the treatment of HE. And what they found was actually really fascinating was that the go lightly had a faster time to resolution of HE versus lactulose, and it was actually better tolerated. And so, and this is a nice forest plot which looked at, and this was later meta-analysis looking at the administration of PEG versus lactulose, and showed that PEG was really a better therapy across all the measurements. And so you had more significant decreases in HE grade, higher proportion of patients with grade 0 at 24 hours, and shorter time to resolution in all patients. And so I want to query the second and third years. Have you ever guys seen us on LTU just start giving go lightly to our patients? So Steph, have you seen that? Yeah. So there's also a really nice anecdote about the story. So this study came back in like 2014 before I started residency. This might be an urban legend, but apparently one of our hepatologists here at UCSF ended up treating so much encephalopathy with go lightly that the supply of go lightly actually ran out in the hospital. It's effective. People use it. Don't be surprised if you're rotating with me and I tell you to start go lightly on a patient. Rifaximin is effective. It reduces hospitalization. Its use is cost effective. There's like 8-9 different studies that have shown that rifaximin reduces the episodes of breakthrough HE, need for HE related hospitalizations, lengthful hospitalizations. But I think the major problem in the case of rifaximin is that many insurance companies, haven't seen the light and don't approve them upon discharge. And so really getting a supply for outpatient use is super important because that's what's going to keep them out of the hospital as well. Okay, so you gave him 4 liters of bowel prep. Great job. He's now ANO times 3. He's now extubated. His abdomen remains distended. He doesn't have tenderness or pain pump palpation. He doesn't have fever, leukocytosis, and also it's a Saturday. So what do you want to do about the ascites? So, sorry, I think my slides a little bit are a bit messed up because like the animations are basically sort of like executing. So what are the next steps for evaluating worsening ascites? The answer is already given to you. Basically, you want to do a diagnostic para with fluid sent for culture and blood culture bottles. And despite the fact it's a Saturday, you should still do the diagnostic para or try to convince the medicine teams into doing it. And so this is a nice summary of the evaluation of ascites. You want to get a diagnostic para, you want to get the fluid albumin as well as the protein, and you really want to calculate the SAG, which is defined as the serum albumin minus the ascites albumin, to see if this is going to be a high SAG ascites or low SAG ascites. High SAG usually implies that this is cirrhosis or heart failure. Low SAG is like you're thinking about peritoneal disease, and this is a whole different workup for potentially malignant causes of ascites. This is a nice table about the diagnostic para studies you should get. So on the first para, you should always get the stuff that calculates your SAG. You should get a cell count, culture, protein. And then, getting glucose amylase and cytology, this really depends on your clinical suspicion. Do you think that this is a malignancy or a pancreatitis that's going on? And then for subsequent paracenteses, typically you definitely want to get cell count culture and then a protein every once in a while just to determine if somebody needs primary SVP prophylaxis or if you're concerned about secondary peritonitis. But if you don't remember anything, the most important things you should get is basically albumin, protein, cell count, and culture. Those are you should always get, and that's part of your usual studies for your paras. All right. Okay. I think that this question is actually working. So when should you do a paracentesis on a patient with worsening ascites? Maddie, are you still on?
Yeah, I'm here.
Hey. All right. So what's your answer?
I would say in an ideal world, like A, I think realistically the answer would probably be B.
Yeah. And it's Saturday. Do you still want to do a para?
Yes.
Okay. What about waiting for IR until Monday? Is that the answer?
No, that would be I would call that suboptimal.
Yeah, that's completely unacceptable. Okay, so yes, so ideally within 1 day, and the faster better, but 1 day I think is reasonable. And there's a couple of studies on this. This is last time that this was studied back in 2019, done by the Cornell group. They show that early paracenteses are associated with better outcomes. 30% of patients with SVP really don't have any symptoms of infection. The paracenteses within 12 to 24 hours is associated with a lower length of stay, less HE, less AKI, lower risk of death. And sort of like, and I put in all these sort of like corny jokes about being Saturday and Monday, but early paracentesis is really less likely during a weekend admission or hospitalization at a non-transplant hospital. And so really you're looking at like less than 24 hours is the goal for paracentesis. I think there used to be a saying over at the at MGH amongst the hepatologists there that they say that you should never let the sun set on a diagnostic tap. As in, if you see a patient coming in with ascites, you should tap it before the sun sets because it's really really important for for management of SVP. Now, one of the major things in SVP is that we give albumin for prevention of HRS. And this is backed by evidence, from pretty far back in the early 2000s, late 1990s, where they looked at a randomized control trial of 126 patients with SVP treated with albumin versus no albumin. And so this kind of established our regimen about giving 1.5 grams per kilogram on day 1 and then 1 gram per kilogram after day 3. And the impact is really the highest on your sicker patients, which is defined with a creatinine above 1 and bilirubin above 4. All right, so you do the diagnostic para, there's no SVP. His creatinine now goes from 1 to 2. He's on Lasix and aldactone as an outpatient when we didn't stop it when he came in as an inpatient. So how do you evaluate AKI in patients with cirrhosis? Or what do you do for treatments on your first steps? Let's see. Is Ava on the
Hi.
call?
Yeah, I'm
Hey,
here.
cool. So what do you want to do?
Hmm. I think I would do C, hold the diuretics and give albumin.
Are you sure? Don't
Oh,
you want to diurese with the AKI?
no,
We
I'm
talk
not gonna
about that.
diurese through the AKI.
Okay. You're not concerned about heart failure causing this?
Not at the moment. That's lower on my list for him.
Great. Because this is a cirrhosis talk.
Yeah.
And sometimes I do treat heart failure, but not in this case. So yes, it is hold the diuretics and give IV albumin. So did you guys know that there's like a ascites club? Like I think the second, third year fellows have heard me talk about this. So apparently there's an international club of ascites. I'm not a member of the ascites club, but if you guys remember Joe Colaro from who was an attendee here a couple years ago and was a fellow here, he's definitely a member of the ascites club. And apparently the ascites club have like all these wonderful meetings in really exotic places in Europe. So it sounds like a really really fun club. But they actually the reason why I mentioned that is the International Ascites Club defines what is AKI in patients with cirrhosis. And actually, this is what we call for. This is their definitions are what we use to grade basically what used to be called type 1 HRS and type 2 HRS. And so what AKI in cirrhosis per the Ascites Club's definition is that your baseline serum creatinine is a creatinine that's within the past 3 months, or the creatinine that's closest to the emission, and and then your AKI definition is basically an increase in serum creatinine of 0.3 within 48 hours, or increase of 50% within the prior 7 days. And so by this definition, it is associated with ICU transfers, longer hospital stay, and increased in-hospital mortality and 90-day mortality. And so they have also defined HRS AKI, which used to be called type 1 HRS. But really, this talks about the diagnostic criteria for what is HRS. So you have to have cirrhosis with ascites, which I think a lot of people sort of overlook, that you have to have ascites for this definition to be true. You have AKI as defined by this definition, which is the serum creatinine increase by 0.3 and also increase over 50%. And then you have no response after 2 days of diuretic withdrawal and volume expansion. This is what Ava answered, which is stopping the diuretics and giving albumin. There's no shock. There's no nephrotoxins. There's no signs of structural kidney injury. So on an ultrasound, you don't have like hydro. Your renal ultrasound looks normal, and there's no microscopic hematuria or low urine protein. And so basically, this is a nice flow chart about how do we manage AKI. You look for the precipitants. If you identify non-HRS cause, you should get nephrology involved. But if you don't have a precipitant, then you hold diuretics. And a lot of times it depends on sort of like if there's immediate improvement. But what we typically do is just give the IV albumin times 2 days. And then if you don't have a improvement, you end up going for treatment for HRS. The treatment for HRS, and I think a lot of this will depend on where you are. At UCSF, we have terlipressin now, and so that's a pretty common thing that we do here. Remind me, at ZSFG and the SFVA, do we have terlipressin available, or is it still the what we call the MOA? It's been a while since I rotated there before.
Yeah, and I think we technically have terlipressin, but I haven't actually seen it used.
Got it. And Pooja responded no turley as ESFG. And so this is still applicable. Usually this is what we call the MOA, which is midodrine octreotide and albumin. And typically, you would start midodrine, anywhere from like 10 to 15 TID. You start the octreotide, which is also TID, and then also albumin dose about like two bottles per day. Now, the whole idea, the whole underpinning of this, and there's some research that's coming out that supports this, is that you want to drive their MAPS as high as possible, ideally above 70, which is ridiculously hard to achieve in our patients with cirrhosis because they're all vasodilated and they tend to have lower MAPS. But the evidence has shown that higher MAPS helps with reversal of HRS. And this is why at some places you can actually run low dose norepi to get them at that higher MAPS. Turley is the new kid on the block. And this was really based on the the confirmed trial that came out in 2022. This was one of those gold standard randomized placebo-controlled trials with 300 patients with HRS AKI. They looked at terlipressin plus albumin, and just a historical note, terlipressin was actually available in Europe for a very long time prior to this, and so we were just waiting for this trial to occur in the United States to get access to the medication. But what they found was that there was a higher rate of HRS reversal. There was a higher rate of HRS reversal without the need for dialysis. It demonstrated reversal in situation of sepsis and SIRS. But was kind of interesting was that it was not associated with a reduction in the rate of death within 90 days, and not associated with an increase in liver transplantation. And so I think like when we dig into the data, and this was actually very nice, we discussed this in Journal Club a couple of times, both in GI fellowship as well as transplant fellowship, that there were actually a lot of adverse events that were associated with terlipressin. Notably that there was a higher risk of respiratory complications, notably acute respiratory failure and overall respiratory failure. And this was thought to be because there was increased systemic afterload that was caused by terlipressin. And a lot of these patients end up getting albumin prior to getting the terlipressin, and so you got also an increase in systemic preload. And so when the FDA approved this back in September of 22, they gave a couple of warnings, notably that patients with creatinine above 5 are unlikely to benefit. So those patients you should really just think about putting them on dialysis. You should avoid in patients with severe volume overload or severe ACLF. You should avoid not use in patients with SpO2 less than 90, and this was really sort of like concern about respiratory compromise. And you shouldn't use in patients with bowel, coronary, or peripheral artery ischemia. There's been some additional studies, post-hoc analyses of the trial data show that earlier initiation really indicated much greater benefit. So you should try to, if you have access to terlipressin, try to use it as soon as possible. And this was segmented based on their creatinine. And so, terlipressin, if you have it, it's wonderful. But if you don't, you can stick with the old MOA combination. And when we're talking about HRS, AKI, one of the questions that classically came up is that should my patient get a TIPS for refractory ascites? And so the question I want to pose to the group is which patient or patients is or are candidates for TIPS? And so who have I not called yet? Is Sean on the line? Sean's doing an ICU card case. Thanks, Royce. Okay, this will be a free. Did I miss anyone in terms of first year fellows?
I don't think you called me yet. This is Quentin.
I'm sorry?
This is Quentin. I don't think you called me yet.
Yeah, hey Quentin, how's it going?
Pretty good.
All right, yeah.
So going through the answers, I think A, the MELD is too high to be a candidate.
Yep.
I think B would be a candidate. C, maybe the platelet count is too low, but I think D would be a candidate also. Say B and D.
Yeah, you're right. It's B and D. C, so just a couple of comments. A, yes, you're correct. That person's probably too sick for TIPS. And C, when you find large varices on routine endoscopy, the first step is to try to manage it either through pharmacologically or endoscopically. And so F is correct. You're looking at a patient who submitted with variceal bleeding. And this is really talking about the preemptive TIP strategy. And then B is somebody with a typical refractory ascites indication. So why do we do TIPS for refractory ascites? Well, not only it's more convenient for patients if you do get a benefit from resolving ascites, there's a pretty substantial survival benefit if you're looking at a couple of studies from previously, the TIPS group versus the LVP plus albumin. You have a lower risk of mortality when you got TIPS. And this logically makes sense because every single time that you end up getting a large volume para, it's a needle through the abdominal wall, and that could be associated with various complications. And one of the things that we fear about doing large volume paras on a frequent basis, and this is why we give albumin, is that you're concerned about tipping them into HRS. And so it makes sense that TIPS will be better for the situation. One of the biggest concerns about putting the TIPS into somebody is in hepatic encephalopathy. They've actually done retrospective studies looking at the incidence of hepatic encephalopathy. It's very similar in patients with TIPS versus large volume paras, but the one notable thing is that severe HE is probably more common with TIPS. But the caveat is that all of the other portal hypertensive complications actually improve with TIPS. So you get less GI bleeding, less SBP, less HRS. And so you really have a benefit that even if there's a mild worsening of encephalopathy, you got benefits from just relief of the portal hypertension. Contraindications to TIPS, there's a few relative contraindications and absolute contraindications. I think the things I think about where I'm going to be tipsing somebody is basically, do they have right-sided heart failure? Because you don't want to put them into worse heart failure. Do they have encephalopathy that is barely managed on two regimens? So like lactulose and rifaximin, and they're still having trouble. Then that's not somebody that will go for the tips. And then the other thing that you want to look for is basically, is their MELD score above 18, which the classic teaching is about 15, but I think we've had now some good evidence that patients with MELDs of 15 to 18, and this is according to the original MELD score, that they actually do quite well with tips, and a tolerability that we're looking for less than 3. All right, so I think one of the more interesting or vexing questions was that, what do we consider to be refractory ascites? Because this has never been defined in the guidelines until more recently. And so it used to be that, back in 2009, they called ascites, refractory ascites is basically somebody that is intolerant to diuretics. EASL in 2018 said very frequent requirements of LVPs or those paracenteses are ineffective. So one of the bigger sort of like changes since 2020 is that now we're defining refractory ascites is after 3 large volume pairs in 1 year, despite adequate diuretics. And so what this means is that we probably were not aggressive about tips previously, and we should be a lot more aggressive about putting these into our patients because of the benefits. And 3 large volume paras is definitely less than what we think a refractory ascites should be, because I think a lot of our patients are actually walking around getting large volume paras every 2 weeks or so. And so in those patients, I tend to be very aggressive about thinking about tips and try to get them ready for tips. Now, going back to Quinton's answer about the patient with Charles B cirrhosis and coming in with bleed, this is the idea behind the preemptive tips. And so this was a study that was done by Lupe Garcia Zhao over in 2010, that looked at patients coming in variceal bleeding, what should be the practice for early tips. The greatest benefit is in patients with child C cirrhosis. There was observational studies that confirmed this, but patients with child B cirrhosis, if you scope them and they are demonstrated to have active bleeding at the time of endoscopy, they also benefit from tips as well. So this really, I don't think we do this on a regular basis, but there's some good evidence about going to tips for this subset of patients who come in with bleeding. Now, I do want to caution everyone that this is called preemptive tips. This is not a salvage tips. A salvage tips is really defined in the clinical scenarios we'll see for our Minnesota tube training, where somebody comes in for bleed, you go in with endoscopy, you cannot get control with band ligation, they're still bleeding, and that's when you put in a Minnesota tube for them to be a bridge to a salvage tips. A salvage tips is defined as a tips that's placed as a sort of like as a last ditch effort to stop the bleeding. In those situations, you should not worry about the MELD score. You should not worry about whether your child's B or C. You should just proceed to control the bleed. And I think like this is a point that a lot of times people get wrong. But in those situations, the tips is absolutely indicated in the acute situation to get the bleed under control. All right, so we put a tips in the patient. The next day, he's now developing worsening ultramental status, oxygen requirement, and his AKI is now getting worse. And this is one of the feared complications about tips, where there's a redistribution of the blood flow inside a liver that has cirrhosis, and you may now precipitate worsening liver failure. And so this kind of gets to the question about, is this acute on chronic liver failure? And this is a talk that we'll save for another time because it's a more advanced topic. But we talked mostly about acute decompensations with in this talk, which is ascites, infection, GI bleeding, and encephalopathy without end organ failure. ACLF is really defined as basically you have an acute decompensation. You also have extrahepatic organ failures, as in renal failure, being in shock, or brain failure with severe encephalopathy, and you have a high short-term mortality. And ACLF is actually its own very distinct entity. The way that I like to explain this is basically think of you have acute decompensation of congestive heart failure as our acute decompensation of liver disease, and you have cardiogenic shock, which is our ACLF. So here's the final question. So, and this is a question that you'll probably get on your consults is when should you call LTU? Which patients should you refer for liver transplant or evaluation urgently? So you got a 54-year-old man in our case scenario who is now 3 months abstinent and now with decompensation after TIPS. Your MELD 3.0 is 34. Choice B, you got somebody with non-ischemic cardiomyopathy, decompensation hep C cirrhosis, MELD is 29. Choice C, you have somebody with NASH cirrhosis, BMI 45, multiple decompensations, MELD is 32. You got a 75-year-old man for choice D with hep B cirrhosis, now with acute liver injury from hep B flare because he stopped his medications, MELD is 37. And then you got choice E, which is somebody with AIH, now has acute kidney injury on top of CKD on CRT after vascular bleeding, MELD 28. So this goes out to all the first year fellows. Who should you recommend or who should you call the LTU for? Royce, you want to get started? Who you can call?
Uh, hmm.
You don't have to choose one. So
Oh, I would call for A.
okay. All right. Let's popcorn to ZSFG. Who'd you call?
I am. This is for on the inpatient side that we're having them transferred to LTU.
Yeah, so basically you're asking your attending if LTU should be called for a potential transfer for transplant eval. So who should your attending call?
I guess if there was any like sign of asterixis or something concerning that the ALI is turning into ALF, I would call that.
Okay.
I also if she's on CRT, like that means she's in the ICU, hypotensive. If she has no grade, and this is HRS that's causing the AKI, that might be also a good reason for a expedited eval.
All right. What about the VA?
I mean, I would say that it seems like a lot of these answers, like you're trying to suggest, like, oh, like this might be a slam dunk, like contraindication to transplant, like for example, in B with the non-ischemic cardiomyopathy. But I would say that like pretty much all of these people would have a terrible outcome without transplant. Like they're at risk for a really terrible outcome without transplant. And I'm not a transplant hepatologist, you know, like who's to say that the person like B, for example, wouldn't be like a simultaneous like heart liver. Like I think I would err in the side of caution and at least like verbally present these people. Like I would say like the majority of these people um to LTU just you know, so that I'm not unilaterally making a decision about like who is and isn't a transplant candidate in these like really sick individuals.
Quentin, do you agree, disagree?
Overall agree, yeah.
Yeah, so this was a trick question. The answer is all of them. And I tried to work in basically things that you think may discount their candidacy. So 3 months abstinent, we don't have an abstinence requirement at UCSF anymore. So this is called the early liver transplant ELT pathway. Non-ischemic cardiomyopathy, we started doing heart livers, a year ago. And so this patient could be considered for heart liver transplant. BMI 45, that's not an absolute contraindication. People think that this might be, but we've done transplants in patients who have obesity. 75-year-old, this is the literature base that Gen Lai really developed, that your chronologic age is not the same as your physiologic age. And so if you're 75 and you have good functional status and your liver frailty index is quite low, or your PT eval is great, then we would consider them for a transplant eval. And so the actual answer is all of the above. So if you see any of these patients, you should discuss with your attendings, or if you're practicing outside UCSF or within UCSF after your fellowship, you should give us a call and just let us know about the case so that we can talk it over and see if they're going to be a transplant eval. So And this is just to go through indications for liver transplant evaluation, acute liver failure as below presented in the last presentation, cirrhosis or portal hypertensive complications. We're talking about HE encephalopathy, bleeding, pulmonary syndrome, hydrothorax, hepatorenal syndrome, and also a male typically above 15 or Child-Pugh's male less than 15 and refractory symptoms. And then MEL exception points, which you're thinking about the HCC, HPS, portal pulmonary hypertension, amyloid, cystic fibrosis, and also HAT and HHT. And this is important because especially for these patients that need an expedited evaluation, their window of opportunity to transplant is quite short, and they might be one decompensation away from dying. And so it's really important to let LTU know as soon as possible so that we can see if they're a transplant candidate. All right, that's all I have. Any questions? And thanks to the first year fellows for participating.